Hi everyone, my name is Sahil Chawla and I'm a medical student at the University of British Columbia. In this video, I'll be speaking about cold-induced injuries, specifically frostbites. For today's discussion, we'll start with an introduction, we'll review normal physiology, go over pathology, causes, clinical presentation, and also the different management options that are available. So to start off, what is a cold-induced injury? Well, it's an injury that refers to severe damage to skin and tissue caused by exposure to freezing temperatures. It occurs when there is failure of the normal protective mechanisms against freezing environmental temperatures. Also, it most commonly occurs on the extremities such as the hands, feet, ears, nose, and lips. Now, cold-induced injuries can be divided into two types, freezing and non-freezing. So, a frostbite is a freezing cold injury where ice crystals form in the tissues and can result in damage to the skin and below tissues. Alternatively, non-freezing cold injuries do not have crystal formations, but they do have local or systemic injury resulting from a loss of heat. This includes frostnip, where there is superficial reversible freezing that starts as pale and cool and progresses to being red and slightly painful. Trench foot or cold immersion foot, which results from acute prolonged exposure to direct wetness at a temperature above 0 degrees. This can result in blisters, tissue loss, and cold sensitivities. Finally, chilblain or erythema pernio results from chronic intermittent exposure to cool, humid air greater than 0 degrees. This results in red, painful patches of skin, most commonly seen over the anterior tibia, dorsal hands, and feet. Next, let's take a look at normal physiology. So, to understand how a frostbite occurs, it's important to understand how the body's normal protective mechanisms for maintaining temperature works. Normal body temperature ranges from 36.2 to about 37.7 degrees Celsius by the process of thermoregulation. This is achieved through a complex interaction of heat production, heat loss, and heat conservation mechanisms that require both autonomic and voluntary functions. The purpose of thermoregulation is to maintain core blood temperature. When the body temperature is challenged, this may result in blood being shunted to the core at the expense of the extremities. Now, this vasomotor response in cold environments is also known as a hunting reaction, where vasoconstriction alternates with vasodilation in 5 to 10 minute cycles to help conserve core heat and allow extremity perfusion and viability. Also important to note, the stages of hypothermia are defined by core temperatures. This has a major impact on both recognition and treatment. The most commonly used definitions are as follows. So, mild hypothermia, that's defined as core temperatures between 32 degrees Celsius and 35 degrees Celsius. Moderate hypothermia, between 28 degrees to 32 degrees Celsius. And lastly, severe hypothermia, which is anything below 28 degrees Celsius. Now, let's take a look at an example of what happens during extreme cold. First, the body's central nervous system, specifically the posterior hypothalamus, receives a signal from sensory receptors about the exposure to cold temperatures. Once a signal reaches the brain, a signal is sent to maintain the core body temperature. This results in two processes. One, there is stimulation of the hypothalamic pituitary axis, resulting in catecholamine release, which acts on smooth muscle cells that line the arteries and arterioles. This results in vasoconstriction of the arterioles in the skin, allowing the body to shift the blood to more vital areas of the body. It also results in the inhibition of sweat glands as the body's attempt to retain heat. And secondly, thyroid hormone. In this segment, the thyroid hormone is released, which acts on the skeletal muscles, resulting in quick contractions, otherwise known as shivering. As the body forces the muscles to work via shivering, it will break down ATP via oxidative metabolism, which will also help release heat. Next, let's take a look at pathology. So, frostbite injuries occur first as a result of direct cellular damage and death, and secondly from tissue ischemia, which is a delayed process mediated by progressive tissue ischemia. When the temperature drops below -2 degrees Celsius, ice crystals begin to form in the extracellular fluid. Due to the osmotic gradient, the water moves from the intracellular compartments to the extracellular compartments. This can cause cell dehydration and cell death. This dehydration causes changes in proteins and lipid conformation, as well as changes in pH and other biochemical processes such as electrolyte concentration, and all of this eventually disrupts intracellular hemostasis. Now, let's take a look at risk factors and etiologies of frostbites. So, in regards to risk factors, some of them include altered level of consciousness, homelessness, comorbidities such as atherosclerosis, diabetes, wound infections, etc., smoking, and outdoor sports or occupation. In regards to etiologies, these can be divided into 1, environmental factors, or 2, host factors. In regards to environmental factors, these include temperature, length of exposure, wind velocity, altitude, especially since there is less tissue oxygenation at greater altitude, and also wetness of clothing. In regards to host factors, this includes compromised circulation. For example, if someone has pulmonary vascular disease, if they're a smoker, if they smoke, or if they're wearing tight clothing. Next, another host factor is also if they had a previous frostbite, which actually doubles your risk of another frostbite. In regards to clinical presentations, there are 4 stages to a frostbite. The first degree is a transient stinging and burning sensation with signs of erythema, edema, and pain. The injury is partial thickness, and the skin may or may not desquamate over 5 to 10 days. This type of injury will irritate the skin and causes pain along with numbness, erythema, and edema. For a second degree presentation, patients complain of numbness, and there is full thickness skin freezing. It appears to be red, has edema, and there are vesicles with clear fluid. For a third degree presentation, patients describe shooting, burning, throbbing, and achy pain. There is full thickness skin and subcutaneous tissue affected with minimal to no sensations initially. There are violaceous and hemorrhage blisters and skin necrosis present. Occasionally, it will feel like a block of wood, as described by multiple patients. Also important to note, third degree involves all layers of the skin and can cause permanent tissue damage. There's also dark hemorrhagic blisters that can evolve into thick black scars. Lastly, fourth degree. In this stage, patients complain of significant joint pain. The injury is full thickness and involves skin, subcutaneous tissue, muscle, and even bone. There's little edema present, and the skin is initially mottled deep red or cyanotic and eventually can become dry, black, and even mummified. This one is pretty severe and can lead to necrosis, gangrene, and even full thickness tissue loss. So for this next slide, it's going to be a bit more graphic, and it shows the 4 different stages on actual human skin. So first degree, we have slight erythema and edema, but really no visible changes are present. Second degree, more prominent erythema as seen along the thumb and the pinky. For the third degree, we start seeing more depth of the skin and the subcutaneous tissue. And for fourth degree, it's pretty evident that there's gangrene present. Also important to note, it can take from 6 to 24 hours for the blisters to appear, and it can take up to 24 to 48 hours after the injury has thawed before you can actually classify the depth of the injury. Moving on, in regards to management and treatment, there's actually 2 parts. The first part is frostbite care protocols. This is what happens inside the emergency room. And second part is what happens after complete rewarming once the patient is a bit more stable. So for the first part, we want to admit frostbite patients to specialized treatment units, begin immediate rapid rewarming. Ideally, this will be performed at a temperature of 40 to 42 degrees Celsius for 15 to 30 minutes or until rewarming is complete. And sometimes this can even be started pre-hospital, but there should be absolutely nothing happening if there is a risk but there should be absolutely no rewarming happening if there is a risk of refreezing. Also important to note, there's two types of rewarming: passive versus active. Passive refers to externally placed blankets or being in a warm room, and active warming refers to being in a warm water bath, having heating pads applied to you, or using warm IV fluids. Also, do not start to actively rewarm patients' extremities prior to warming the core. Also important to note that at this time, patients will be able to perform active range of motion, but there should be no passive range of motions being performed. Afterwards, when complete rewarming has happened, we can begin to debride white blisters and initiate topical treatment with aloe vera gel Q6 hours. You want to leave hemorrhagic blisters intact, elevate injured parts and splint as required, make sure that there's adequate tetanus prophylaxis, administer appropriate analgesia, antibiotics, and ibuprofen, use daily hydrotherapy or gentle wound care, and also thrombolysis can be considered within 24 hours of injury for high-risk, life-altering amputations. Lastly, you want to make sure to document at 3 different points. 1 at admission, 2 at the 24-hour mark, and then thirdly, once every 2 to 3 days during hospitalization. Lastly, we'll focus on surgical and non-surgical options and then also complications that can happen. In regards to surgical options, there's 1, debridement possible, and 2, possible amputation, which is indicated for early uncontrolled infection or even after 1 to 3 months once the injury has fully demarcated. Non-surgical options are primarily wound dressings. In regards to complications, these can include altered skin pigmentation, cold sensitivity, chronic pain, stiffness, and loss of range of motion or even function. So, to recap, frostbites are an injury caused by freezing of the skin and underlying tissues. There are 4 degrees of frostbites and they can happen anywhere on the body, but fingers, toes, nose, ears, cheeks, and chin are the most common. When the temperature drops, crystals form in the extracellular fluid, and the osmotic gradient pushes water from the intracellular compartment to the extracellular compartments, causing cell death and eventually ischemia. Some causes of frostbites include inadequate clothing, wind chills, wet clothes, smoking, alcohol. Now, when a patient presents with a suspected cold-induced injury, it's very important that we do not begin rewarming if there is any risk of refreezing. Also, the goal should be to begin immediate passive rewarming once there's no risk of freezing at 40 to 42 degrees Celsius for 15 to 30 minutes, and then once that's happened, active rewarming can follow this. And lastly, always ensure that the core temperature is warmed prior to warming up the extremities. Thank you so much for watching this presentation. I hope you found it very helpful, and if there are any questions, please feel free to direct them to the UBC Plastic Surgery Department, and we'll be more than happy to begin answering your questions. Thank you so much.